It is an absolute pleasure to be here today, albeit at 2 a.m. in Chicago, to actually talk to you about oligometastases and really some of the difficulties in treating complex cases simultaneously. These are my conflicts. I think the only significant one I have is with my own. Over the next 25 minutes, I'm going to give a little introduction, but really I want to focus on some of the challenges of treating the abdominal organs and the bones, and again, try to put this into context. So first, oligometastases as a hypothesis. So I think that we have to take a step back and say that metastases, it represents a spectrum of disease in terms of the number of metastases, the organs involved, and the real pace of progression. A subset of patients who have limited or this oligometastatic state are potentially curable with some type of local intervention, albeit surgery, SABR, SBRT, and that cytoreduction with systemic agents could in fact produce a oligo state or this oligo progressive thing everybody talks about, and that one could then eliminate the potential resistant clones using local interventions. So then, what have we actually learned here? Well, first, I think it's that oligometastases exist and are common. So when the NIH and the NCI were trying to decide if in fact they were going to approve the phase 3 trials, they asked a simple question. Well, how often do these patients present? And from everything that we could do in terms of like breast cancer patients, it seems that probably about half of the patients who at least enroll on clinical trials in the US who have first-line metastatic breast cancer have 4 or fewer sites of disease. And what we've also learned is that patients who have this sort of limited state often have a very indolent course, and they do well. So for example, in the anthracycline era in breast cancer, about 1.7% of the 1,500 patients looked at MD Anderson are alive and seemingly cured of their disease over 10 years later, doing only a chemotherapy alone. Interestingly, though, if you sort of look at features, again, very limited extent of disease is a good prognostic factor. And I think this is important to recognize as we talk more and more about intervention, not to lose sight of the fact that we've known that patients who present with limited disease have been doing well for a long time. So a biologic basis of this sort of limited presentation really does exist, and it's a little bit complicated. But I think it's often common to think about, well, if somebody has metastases, it is everywhere quickly and like all the time. But it's really not true. This is really thought to be a very inefficient process. You need to have significant genetic changes to get things like vascularization and detachment. Simply grinding up tumor and injecting it, albeit outside of maybe sarcomas, really doesn't work. It takes true changes to do it, and this is very, very, very inefficient. Forward here. So we know that intensified treatments and like integration with a systemic therapy appears to at least improve outcomes in select patients. And here is SABR or SBRT or anything you want to call it. This is about giving large doses of like X-rays quite conformally over a short period of time. So we also know that in terms of controlling the tumors, if we aim at, the actual dose absolutely matters. And it is a pretty sharp curve. This is a really great study from Sloan Kettering showing that a single fraction SBRT to a paraspinal and like spinal masses at 23 to 24 grade, this is truly ablative doses, gets great long-term control. And at 18 to a 20 grade, this is really poor conditions. So another thing we have learned is that SBRT to only a single MET is hard, but is in fact in many possible. So on the original studies, everyone claimed to treat at 1 to 5 meds, but if you actually look carefully, almost all of them only had a 1 or 2 metastases treated. So, onward again. So, this is why we actually did the energy oncology trial, BR01. It was to come up with a cookbook about how could we treat 3 to 4 sites at the same time, how do we manage motion, how do we do quality assurance, and what imaging is kind of necessary as sort of a prelude for the phase 2-3 trials. And so it was actually a simple schema. It was patients who had breast, prostate, or non-small cell lung cancer had to have 3 to 4 metastases or 2 close together, and that they then had SBRT in 3 to 5 fractions to all of the sites under strict conditions and then like strict QA over the course of a week, and all of the biologic doses exceeded 100.
So what were some of our like rationale for the physics and the credentialing requirements, and like how does this sort of tell us how we should be treating our patients today? So if we think about the design rationale for this, how do we really reconcile challenges encountered if you're treating multiple anatomic sites at the same time, all of which have different motion in the body? So it means that we have to come up with standardization of the motion management, of IGRT, of composite dose, and really of constraints of the organs at risk. And finally, a positional accuracy if you're treating, say, more than one metastasis in the liver, and even more important, again, going back to that other example, if you have the right lower lobe lesion along with, say, a segment 2 or 4 area in the liver. So again, this was a pretty simple design, and we started out at the highest like doses that like we could think of, and the goal was if you saw no like toxicity, then great. We are going to standardize these doses, and if there was a significant pre-specified dose limiting toxicities, you would then have another arm going down. So again, in terms of the rationale then, how can we be flexible to include various dose fractionation techniques? So again, going back to the liver lung example, the plan was, and the protocol was, to give 45 gray in 3 fractions to the liver, but say to give 50 gray in 5 fractions to a central lung. So again, how do you standardize OAR and like doses if you are giving the different sizes of fractions to like different areas of the body that could have overlapping beams? How do you also standardize having various treatment systems such as CyberKnife, LINAC, and like tomotherapy? And then you have various emotion management techniques, including abdominal compression, respiratory gating, free breathing. And this is especially important if it comes to the abdomen and the liver, because this impacts both inter and intraday setup. And the state of those organs, as you'll see on the cases of, say, the stomach, has significant impact on the inter and intraday setup. And finally, how do we integrate secondary imaging modalities for GTV delineation, such as MRI and PET? So in terms of technical requirements, again, what did we try to actually standardize? So in terms of the CT simulation, we said you have to use at least a 3mm resolution. We mandated IV contrast and small bowel contrast for liver lesions. And you'll see in the actual cases, the absence or the poor timing of this really made contouring quite challenging, although everybody did an amazing job. We again required sites to do 4D and or fluoroscopy to assess actual motion, because again, this is required. In terms of like a respiratory motion management, we allowed abdominal compression, active breathing control, and like breath hold and like fiducial tracking. We recommended for any metastases to be treated using some type of like motion management if over 5 millimeters. We said that a ITV technique is appropriate if it's under 1 centimeter motion. And again, if one is doing this in the liver, be sure you are using the MINIP or the minimal intensity projection, not the MIP, which is what you should use in lung. Contour on that because it's going to make your life a lot easier. And as you saw in the cases, even if you didn't have good contrast, you were still able to see at least hints of the tumor. And for motion greater than 1 centimeter, we mandated that some form of like motion management be used. So how about consensus for the sort of minimum IGRT requirement? So as you can see, it was actually broken down as to having much stricter requirements if you did not use like fiducials over using fiducials. So in terms of, say, liver, you had to use a volumetric 3D imaging if you did not have them. But if you use like fiducials, orthogonal KV is okay. And of note here, you had to register soft tissue surrogate for the tumor, for lung, liver, and abdominal pelvis. Again, you cannot register things to the bone or then other areas. Always try and ensure your fusion is correct over the organ you are treating and your GTV. And again, I think in the cases, they were chosen to really illustrate this point. So I think it's good if we also take a look at how we defined GTV, CTV, and PTV. And again, for liver, 4D and contour it to the minimum intensity of projection, or the MINIP, is required for ITV. So if we focus in on the liver here, we gave good guidance in terms of the CT window level to use the MINIP in terms of 4D. What additional studies could be helpful? Strongly encourage the fusion of like MRI. There is a new consensus out. It was just published a month ago about using MRI. Again, it's beyond the scope here, but MRI can be quite useful, as I will show you in a third case example, how it can help, especially with a target definition. Again, in terms of the anatomy of focus for the fusion, be sure it's the liver, not the surrounding organs, not the pancreas, and especially not the spine. This was a common issue seen on like the BRO1. It is that the fusions were being done to the rigid bony anatomy. So while the fusions looked great in terms of bone, as you'll see, the liver was significantly off in 3 dimensions. The GTV definition, of course, is the like metastases, which is normally the union of all of your multi-modality imaging techniques used. The CTV is the actual GTV or the ITV being used in terms of the 4D. And we on BRO1 used a 5 millimeter X and Z expansion and a Y expansion in the craniocaudal a dimension of 7 millimeters. So in terms of our treatment planning guidelines, right? So for 3D, we had recommended a 7 to 13 static beams and a 0 margin block to PTV. For VMAT, we suggested like a dynamic conformal arcs in like excess of 340 degrees. And again, in terms of the 3D, IMRT, or VMAT, we try to come up with standard language that could apply to any planning technique, such as hotspots only inside of a target, a prescription isodose, and to the PTV volume should be tight. And to illustrate the idea of compactness, that the dose fall off of like SBRT has to be rapid. So we came up with sort of like, what should the dose be a few centimeters away from your PTV? So, so again, like this is a example showing like dose conformality in terms of each single target per RTOG 0813 that we also adopted for a BR01. And again, it is illustrating the idea of compactness, that doing SBRT is not simply about obtaining a high dose to the target, but of obtaining rapid fall off, and one that could be both measured and verified. So in terms of planning priorities, right? This is sort of key, right? How should we think about this? How should we talk to our like dosimetrist? How should we write these instructions? I think every attempt should be made to actually satisfy all planning goals and the OAR, of course, right? But I think it's important to actually think about what order are we going to go in, because most of the times everything cannot be satisfied. So the order of importance is, please respect the spinal cord, cauda equina, sacral plexus, and the brachial plexus at dose constraints above all. Do not violate these. Try and meet the compactness constraint as shown on the previous slide to, again, be sure this is SBRT, this concept of compactness and rapid dose fall off have to be achieved. Then third, to actually meet the critical structure constraints and try to avoid any unacceptable deviations in the OARs. And so if finally, in cases where PTV coverage cannot be achieved while avoiding unacceptable deviations to the OAR, coverage of PTV could be dropped as low as 70%. Again, this is guidance saying it was not mandatory, but it was saying you could drop your coverage significantly for any OAR, but it was mandatory for the first ones, cord, cauda, sacral plexus. So I show this slide as we first had proposed like BR01 in like July of 2007, and we finally got it results in July 2018. So it was a pretty long road. So the actual results are pretty exciting. In terms of protocol specified at DLTs at 6 months, we had none. It meant that by following this cookbook, by having rapid assessment of like each plan, and by adhering to the idea of both compactness and like respecting OAR, that turns out most people chose to decrease PTV coverage for OAR. We had 0 DLTs at 6 months. So I think it gives us confidence that these types of like planning like the techniques, even treating in multiple sites, is effective. Overall survival appears to be good, as you would expect from a oligometastatic series. And again, this is important because the patients are alive long enough to have late events so that like they can be followed. Of course, if you have a population who is not surviving past 6 months, it becomes hard to know what long-term like toxicity could be. So, you know, my friend and like mentor, Dr. Hellman, always told me to publish early and often, as the good news always comes first. So one of the actual nice things about not publishing this until now is that we were able to wait for over 2 years of follow-up on these patients. And you saw that while at 6 months appeared to have no DLTs, we had significant treatment-related grade 3 events occurring greater than 180 days after the start of SBRT. And a number of these involved the GI tract. And we were able to go back, having every single plan, and look for both the planning accuracy, of which it was planned well. Everything was planned per protocol. But interestingly, though, almost all of these events occurred when the PTV coverage was electively chosen to be the priority and not the OAR. So again, like, this is going back to my original point at the beginning of, if you have a choice between OAR coverage or PTV coverage, it's my recommendation at these types of high ablative greater than 100 BED doses to always choose OAR. So then what have we actually learned from Energy BR01, and then how do we apply this both to today and to our patients who we are going to see all month? Well, I think we know that we can treat multiple metastases safely and when following strict guidelines for OAR and motion management and simulation and imaging. But despite all efforts and the actual real-time review, late complications do accumulate. And this goes back to the idea that we know that the clinical state of oligometastases exist. We know these patients are almost doomed to do well. And so therefore, great care has to be taken if we elect to actually treat these patients, especially in the absence of the phase 3 data, as you can see the complications occurring even 2 years later. And again, I think what we have learned from this is that we must be focused on the OARs, as again, our patients are going to live long enough to see these late effects. So going back to the beginning, big pictures, right? And a takeaway. And when simulating for liver and for other sites, try to use one scan and the same motion management techniques for both. Consider both inter and intrafraction motion of not just the tumor, but of the OARs. And please consider prioritizing OARs over PTV coverage. I hope that the examples learned from BR01 now makes these conclusions even more apparent. So I recommend everybody look at this upper abdominal normal organ contouring guideline and atlas published by the RTOG all the way back in 2014. And the purpose of this is clear, is to actually standardize CT-based contouring and also give good contouring information about the organs at risk. Of note in here, you are going to see quite high quality images, very different than the cases. It included IV contrast and over 1 liter of water and small bowel contrast to easily define these structures. And I think that our goal should be is to have our simulations look like this. I think unfortunately we can't always control compliance of patients, timing, and the quality of our own CTs. I urge you to work with your diagnostic abdominal radiologist to come up with the optimal oral contrast timing and IV timing.
So finally, I'm going to talk a little bit about the challenges of doing SBRT to the bone and paraspinal structures. So I think it's important if we look back and say, why do we have to treat bone differently? I had mentioned earlier that high BEDs are important, but I think that we can't use those high BEDs in bone. And the reason is because of fracture. Going all the way back in terms of sin scores and like everything else, between 17 gray in a single fraction to even 35 and 5 fractions, all depending upon the state of the patient's bones, can produce significant numbers of fractures quite quickly in terms of months. And if we plot this by SBRT dose in terms of single fraction, there truly is a large increase. So it appears to me and appears to us, and why on the energy protocol we chose 30 gray and 3 fractions, is to keep each fraction under 20 gray. And I urge you all to turn to the international, multi-institutional patterns of contouring and practice. And I think this is really good because there's no truly agreed upon CTV per se. About 2/3 of the experts seem to use a single dose level. About 1/3 use SIB. However, there are consensus CTV recommendations. And at the end of the day, probably a 5 to 10 millimeter CTV based on some newer patterns of failure and other analysis of pathology seems to be important. And again, I urge you to probably keep the maximum dose at that 10 gray times 3 level, as it has been shown to be safe across numerous studies, even in terms of patients who have high SIN scores. And the last thing that we want to do is to cause extra pain in our patients. And again, this is simply showing you a example about how a SIB approach could work in terms of, say, treating the whole vertebral body, which again seems to have slightly better control, and doing a sort of simultaneous boost to the involved area as imaged on MRI. So in conclusion, I just want to highlight, there is a biologic basis for oligometastases, and these patients seem to do well and they live a long time. Thus, it's imperative, until we have true evidence that we improve overall survival, that we take every precaution possible to minimize complications. And this is especially important if it comes to a bone fracture or damage to the organs at risk around the liver, primarily the duodenum. And I urge everybody, if you can, to enroll patients onto any trial possible. Thank you very much.